I'm Mohammed Azan, a second-year MBBS student from Central Park Medical College.
And I am Abbas Murtaza Jafri, a third-year medical student at Central Park Medical College.
I would like to extend our warm welcome to this multidisciplinary team MDT session titled Rheumatology and Dermatology Board, Unraveling Complexities at the Skin-Joint Interface. This session brings together leading experts to bridge the gap between rheumatology and dermatology, two specialties that often converge in clinical practices. Through shared insights and collaborative perspectives, we aim to better understand and manage diseases that blur boundaries between skin and joint involvements.
We are honored to begin this session with a distinguished speaker, Professor Chris Denton, Professor of Experimental Rheumatology, Consultant Rheumatologist, and Joint Director of the Center for Rheumatology at UCL Medical School in the Royal Free Hospital, UK. Today he will be delivering a lecture on assessing disease activity and treatment outcomes of scleroderma, focusing on the latest approaches to disease evaluation, monitoring, and outcome optimization. Please join me in welcoming him to the stage.
Thank you again. I'm delighted to be here and to be part of this multidisciplinary workshop. And it is important, I think, that we work together as specialists. We have joint clinics with our dermatologists and work very closely with them. And I think there are shared concepts in dermatology and rheumatology that we're dealing with conditions that affect the skin or the joints, but also in the context often of multi-system disease. And I think systemic sclerosis really illustrates that. So what I want to do in the presentation today is just to review particularly how we assess the skin in systemic sclerosis and its impact, but also other important organs, and I think the skin and the lung have really emerged as the most important organs for us in terms of making our treatment decisions. So I'll talk a little bit about those, and then bring it on to thinking about in practice and trials how we can assess the disease more broadly with composite outcome indices and with activity indices. So these are my disclosures again. So I will, first of all, start with the skin, I think very appropriate for the workshop today. And I'm going to go through a number of approaches that are used to assess the skin, but not all, because it's a sort of too big a topic really for the time available. But I will talk about particularly MRSS and some of the imaging approaches, and also the ways we're trying to assess the patient's impact of skin. So the starting point, I think, is very appropriately the modified Rodnan skin score. So many of you may be aware of the history. Rodnan was a professor in Pittsburgh who really is one of the father figures for systemic sclerosis, and he developed the Rodnan skin score as a semi-quantitative way of assessing his patients. He had 25 sites and an integer scale of 1 to 4, so the score that he developed had a maximum skin score of 100, but it's been modified over the years to simplify and also become easier to do, more reproducible. So this is the modified Rodnan skin score that we have now. It's a 17-site assessment. Each site is assessed between 1, 2, or 3, depending on the severity of the skin thickening. So what we're trying to do is to rate a fold of skin and assess whether the skin is thickened and how severe is that thickening. And if the skin is normal, it's scored 0. So with 17 sites and an integer score of up to 3, the maximum skin score you can have is 51. Just to put it into context, typically a diffuse scleroderma patient will come to our clinic with a skin score between 20 and 25. So as a scleroderma community, we've really worked hard to try and standardize the approach to skin scoring because we realize it is a semi-quantitative assessment, and there is now a well-established training program organized by the World Scleroderma Foundation and the Scleroderma Clinical Trials Consortium to standardize skin score training, and this operates very well for clinical trials. And it is very important to standardize your training so that we can try and harmonize skin scores in clinical trials, particularly where it's the primary or a key secondary endpoint. We've known for many years that what happens in the skin in systemic sclerosis does reflect what's happening in the disease in general, and in fact reflects treatment outcome. And there have been many studies over many years, and I just highlight some work that came from our unit a little while ago now, but I think it was very helpful in trying to understand that link between skin and disease outcome. So we were puzzled at the time that there was so much variability in our diffuse scleroderma patients in terms of their skin and the changes in skin score over time with treatment. And so we did this study. We looked at 225 patients where we had skin scores over 3 years or to the patient's death for those unfortunate patients that died early. And we looked at the skin score changes. You can see it's a real spaghetti plot. There's tremendous variability. But we worked with biostatisticians in Manchester, at the University of Manchester in the Rheumatology department, and we used linear latent trajectory modelling to simplify that pattern of skin score into 3 groups of patients. So patients had a 95% chance of being in one of these 3 groups. And it had face validity because it reflects what we see in practice. Patients who have diffuse skin disease that gets better with our standard of care, those patients that have much more severe high skin scores, some of which do get better with treatment, some not. Though these 3 groups, which we call perhaps not very imaginatively high baseline non-improvers, high baseline improvers, and low baseline improvers, were very helpful because those patients that had not so bad skin that improved had a much lower frequency of internal organ complications. And more importantly, those patients that had high skin scores that didn't improve at a group level had a very high mortality. So this explains why skin score does correlate with outcome and is a prognostic marker in systemic sclerosis at a group level. But where it's a challenge is to use it at a patient level because clearly there's a lot of variability. So one of the thoughts about trying to improve skin assessment is to try and use a more quantitative measure. So durometry measures hardness, not thickness of skin. But again, using the benefit of a well-conducted clinical trial some years ago, this was the trial of an anti-TGF-beta1 antibody that unfortunately was negative as a trial, but a very positive exercise for standardizing durometry and showing that it correlates very well with the modified Rodnan skin score. So it provides another way of assessing skin, but it doesn't, of course, outperform the skin score, so it provides additional construct validity. And the same might be said of ultrasound. So ultrasound, high-frequency ultrasound, has a resolution to assess skin thickness, and you can also look at the quality of the skin. And this, again, has been proven to be a useful tool to assess skin thickness in a more direct way than we can do just by palpation in the skin score. And a few years ago, in fact more than 2 decades ago now, Ariane Herrick from Manchester showed that the skin score performed using ultrasound scan to directly measure skin thickness could certainly perform as well as the MRSS. But all of these studies really just provide construct validity to the MRSS because they don't take it further forward. And just finally, work that was presented by Shervin Assas's group from Houston, Texas, last year at ACR, really took it to the next level to see whether you could actually correlate ultrasound findings with biopsy in the skin, looking at histology. And unfortunately, the correlation is, other than for just measuring skin thickness, is very poor. So I think we're left with the modified Rodnan skin score, in fact, over time now shown to have very good construct validity from those different approaches, but still a very useful tool to assess outcome in systemic sclerosis. But sometimes we're challenged because we're certainly by regulators and payers to say, well, if you improve the skin score, what does that mean to patients? And so there's been a lot of emphasis now also in trying to find out, get measures of skin impact. So the Scleroderma skin patient-reported outcome, the SSPRO, was developed a few years ago by Bob Leafiatis and colleagues in Boston University, and it's an 18-item simple validated questionnaire that assesses the skin impact really in terms of physical limitations, physical, emotional and social impact of the skin disease. And again, it's been shown to correlate well with outcomes and is used in clinical trials and in clinical practice to assess skin. So it's patients really reporting what they feel in terms of their skin. So we took things one stage further, and this was by necessity during the COVID-19 pandemic, because we were conducting our clinics by telemedicine remotely, but we still wanted to have a handle on what was going on with their skin and their skin thickness. And we discussed with patients how we might do this, and we came up together with this concept of the patient assessment of skin thickness, but we realized that this was quite challenging, so we thought we would just ask them to assess the upper limb, and we came up with what we called PASTEL, patient assessment of skin thickness of the upper limb, and it was really a mitigation for COVID. We published this, we thought it was a useful tool for others to use, but we realized it had a little bit more potential because, in fact, what we showed was that it correlated extremely well with the MRSS that we assessed in the clinic in a more complex way. So we were fortunate that the Scleroderma Raynaud's UK, the main patient charity in the UK, gave us a grant to extend the study. And so what we did was a 4-centre across the UK, the 4 major scleroderma centres, a validation study in nearly 200 patients that confirmed, and we published this earlier this year, that this is a very useful way of patients assessing the thickness of their own skin, in fact, that correlates with what we do in the clinic, but more importantly, correlated with measures of health status and quality of life. So we think this is something that's very useful, perhaps not as a primary endpoint in the trial, but as an adjunct to treatment, particularly in a decentralized trial or with remote assessment. So that covers the skin, which I think is very important, but we want to think about the lung as well. And we've got a number of tools that are listed here, ways to assess lung. Again, I can't go through everything today, but there's no doubt that the high-resolution CT scan is the cornerstone of assessment of lungs in systemic sclerosis, because not only does it allow you to assess the extent of disease, but also the pattern, whether it's fibrotic, whether it's got an NSIP or a UIP pattern. And you also get very useful information about comorbidities, such as the presence of esophageal dilatation and other lung pathologies. And indeed, you can start to use the HRCT now as an outcome assessment over time, and I'm sure there will be more progress over the next few years with machine learning and artificial intelligence, but you can now use quantitative techniques, and I showed earlier in my previous talk, the impact of tocilizumab on lung function, but in the same phase 3 trial, the FOCUS trial, we were able to show very convincingly that the CT changes are also very much in line with those clinical impacts, and you can see there are 3 ways you can quantify lung extent in this algorithm, but basically all of them showed significant improvement on tocilizumab and worsening on placebo. So CT is certainly something we can use in clinic to assess our patients and to follow them. Lung function, though, of course, is non-invasive, and so this is the sort of standard way to assess lung involvement in systemic sclerosis. But the problem is, just like skin, there's tremendous variability in the trajectory of lung function change over time. And here is data for just over 500 of our patients, all with confirmed lung fibrosis on CT scan and with long-term follow-up. And this is interesting because at a group level, the change in FVC is really, even when you've got lung fibrosis that's significant, affecting more than 20% of the lung, is only about between 1% and 2% of decline per year. So it's a very slow rate of decline. But of course, some patients do decline, and they decline to an FVC of 50% or 70%, and these are the ones we really need to pick out. So you can start to try and use predictors to work out what the trajectory of decline is likely to be. But in reality, what we can do with lung function is just simply repeat the test and get an idea of changes over time and how that might impact on long-term outcome. And so I think the way we use lung function serially in our clinic is to look at the change over 6 and 12 months and try to extrapolate what might happen in the long term. And we know that this is a valid approach because, again, in work that we've done in collaboration with the Brompton Hospital, with Athol Wells and colleagues, we're able to show that your FVC change at 12 months can predict your long-term survival, particularly once you've got that extensive stage of lung fibrosis affecting more than 20% of the lung. But the trouble is that you need an FVC threshold of 10% change over a year to really impact on mortality, and that's quite a large change, and it's frustrating to have to wait for that before you might change treatments, for example. So we came up with this composite categorical decline, which is where you've got where you can have a 5% change in FVC, fall in FVC, as long as it's corroborated by a change in DLCO, really just to make sure that that change in FVC is real. And then you can get a very good prediction of survival, particularly in those patients with extensive lung fibrosis. So I think overall now, to assess lung in systemic sclerosis, we've also got quite a mature set of investigations. And as I said this morning, we can identify those patients with high risk diffuse skin disease, less than 3 years disease duration, a high risk antibody, particularly SCL70, but also others. Severe gastroesophageal reflux in a number of studies predicts worsening, and you can use biomarkers. The KL6 is available in some countries, and elevated acute phase, as I showed this morning. If you've got a high ESR CRP, you're likely to have more progressive disease. So you can stage your lung and use serial tests in that way to assess things. So we can assess skin and lung operationally in our patients, but I just want to finish off by talking about some of the composite outcome measures, and I'm going to focus on the composite response index in systemic sclerosis because this has emerged as one of the most attractive outcomes in clinical trials at the moment. And the reason for that is that we know systemic sclerosis is a multi-system disease, and just looking at the skin or the lung doesn't capture the whole of the clinical impact or potentially the therapeutic impact of a treatment. So the ACR-CRIS was developed by a group led by Dinesh Khanna and others a few years ago. And this was developed to try and assess change in diffuse systemic sclerosis over a 12-month period that could be used in a clinical trial or in clinical practice. And it was devised as a two-step process where the first step records whether something major has deteriorated in the patient, in which case they clearly have not responded to treatment. And the second is a composite putting together 5 different relevant outcome measures: MRSS, forced vital capacity, HAQ disability index, patient and physician global, in a score that will determine whether a patient might have responded to treatment or improved in clinical practice. So just to show you how that works in this ACR version of the CRIS. So you've got step 1, where if there's been worsening of pulmonary or renal function, so if they've had a renal crisis, developed pulmonary hypertension, had major progression of lung fibrosis, clearly they have failed to improve and they get a CRIS score of 0. But if that doesn't happen, and usually it won't, fortunately for our patients, then you can move into the step 2 where you compute changes in those 5 variables, and from that, using a mathematical formula, a weighted formula, you can calculate a probability score between 0 and 1 of whether the patient's improved, and they're a responder if their CRIS score is over 0.6. So this score, the ACR-CRIS, has performed quite well in clinical trials, but unfortunately, it was developed in an era when we had very ineffective disease-modifying treatment, methotrexate at best, and in fact it was the methotrexate trials were used to validate this in its development. So it does work very well in clinical trials with effective drugs when there is a true placebo control arm, no background therapy. So it's worked in the ASSET trial of abatacept and in the trials of tocilizumab with nominally significant p-values because it's a post-hoc analysis. But unfortunately, although it works in short-term trials of other drugs when you allow background therapy, so short-term trials of lanabecim or asenjaprast, which is an FT11 peptide inhibitor, it works in those short-term trials. In longer-term trials, and I showed you this morning the Resolve 1 trial, the 1-year trial of lanabecim, it doesn't work. And the reason it doesn't work is that every patient on effective background therapy will achieve a CRIS score of above 0.6 by 12 months. So you can never discriminate your patient on a new drug. And it's shown here, these are data from the Resolve trial. You can see just how that happens. The dotted line are the patients not on immunosuppression. The bold line is the patients on MMF. But you can see the other grey lines, they're on different other disease-modifying drugs. In every case, in fact, the patient almost comes up to close to 1 by the end of study, particularly those patients with early disease. So that led to a wish to revise the CRIS, and so various data sets were used to develop a revised composite response index. And this is the index that's now being tested in a number of clinical trials. The hope is it will be more discriminatory and it will be less confounded by background therapy. So the revised CRIS is very simple in that, in fact, it's simpler than the ACR CRIS because it doesn't have a mathematical formula. It's a categorical approach, really. So you've still got the step 1, which categorizes a patient as a non-responder. But at step 2, instead of using a formula, you simply look for a 25% improvement in HAC, patient global or physician global, or a 5% in FVC. And as long as you've got a responder improvement in 2 and without worsening in more than 1, you'd be classed as a responder. So this is hopefully going to help, and it's being used as a primary endpoint in a number of trials, including the DAISY trial of anifrolumab in systemic sclerosis. Finally, and this is my last data slide, what about activity indices that have really been so transformative in vasculitis, in lupus, and in rheumatoid arthritis? Well, we do have an activity index in systemic sclerosis. It was developed and validated by USTAR. And again, it's very simple, and it simply scores measures that we know associated with activity of the disease, and you get a score. And if the score comes out as above 2.5, you're classified as having active systemic sclerosis. So I'm finished here, but just to say that the assessment of disease is the foundation for good management in systemic sclerosis. We do have good outcomes, I think, for skin and for lung. We're starting to get other outcomes, and I think composite indices that measure the disease more broadly hopefully will be the future. So thank you very much, and I look forward to questions and the discussion later.
As we continue this thought-provoking session that bridges the expertise of rheumatology and dermatology, it's an absolute pleasure to welcome Dr. Katy Leung, Senior Consultant at Singapore General Hospital and Associate Professor at Duke NUS Medical School, Singapore. Today, she will be enlightening us on a topic that lies at the very heart of this session: how can we improve treatment outcomes in psoriatic arthritis? Please join me in warmly welcoming Dr. Katy Leung to the stage.
Thank you for the kind introduction. Yeah, it's my pleasure to talk about improving outcomes for psoriatic arthritis. It's always been on my heart. So it's like we can identify the unmet need for the care of psoriatic arthritis in different stage of the patient journey, before the diagnosis, and then making an early diagnosis, effective treatment, and follow-up. So it's a big unmet need for early diagnosis and getting them to early treatment. Why is it important? We borrow the idea from rheumatoid arthritis. We know it long time ago that when the disease come by, you have high inflammation and high disability. But in longer term, when the inflammation dies down, what really drives the disability is not the inflammation, but the radiographic damage, which means that if you treat them very early, prevent the damage, and later on in life, these patients are much better in their quality of life and function. So why do we care about diagnosing psoriatic arthritis early? Well, erosion actually comes very early, although some of the time we don't x-ray them very frequently, but data is showing us that within 2 years, some of them are already having radiographic damage, and by 2 years, up to 50% already get some erosion on the joint. So Huron, using the Dublin cohort, have very nicely demonstrated just a 6-month delay in the diagnosis of psoriatic arthritis, and you see what happened. It's increasing the odd ratio of having emotion, motor lance, damaged joint, sacroiliitis, and they are less likely to have drug-free remission. So we also see very good data that's showing that if we treat psoriatic arthritis much earlier, say for example, this is a big trial, huge trial, 800 people, and they have very early psoriatic arthritis. If you give them very appropriate treatment, you see the ACL 20, 50, 70 are really breaking the rule of the usual that 20, 40, 60 rule, they are giving you much better results in longer term. And then we also have studies that show that treating to a target is really possible. Look at the Ticopa trial that Loracos run. They're looking into targeting MDA, which is quite easily accessible in clinical practice. And then these people are able to achieve better outcome. Long time ago, we tried to look at radiographic cardiovascular outcome. Very early on, we treat psoriatic arthritis patients with TNF blockers. And then these are the patients who have continuous TNF blockage. Over a 1 year time, we were able to demonstrate a lower intimal thickness of the carotid artery. And Laishan group is take it further. They are able to show sustained MDA are giving them less incident of cardiovascular disease over time. So we know that psoriatic arthritis is giving higher mortality. Majority of these mortality are coming through heart attack and stroke. So we know that if we suppress the inflammation low enough, give them into good clinical remission, in longer term, we may reduce the mortality rate. So, well, for rheumatoid arthritis, it's only the joint. But for psoriatic arthritis, look at it. Majority of the patients are having psoriasis first. So then this is the patient group that we should target to better improve the outcome and increase the early diagnosis. There has been ways like using questionnaires, screen them, and give them a simple questionnaire like the PASS, which is the most simple, only have 5 questions, asking them whether they have musculoskeletal symptoms. Unfortunately, in the external validation cohort, it doesn't work very well. But I think very importantly is really training our healthcare providers to really recognize the disease. Some of these patients go to orthopedic because they have joint injury. A lot more patients are in a dermatology setting or in the primary healthcare setting. They don't even know that psoriasis will be progressing to psoriatic arthritis, which happen in 30% of the patient. So it's really teaching our healthcare professionals to recognize the disease. Some of the risk factor among those who have psoriasis who would develop psoriatic arthritis is well known. There are some of the risk factors that we know, family history. If they have somebody in the family who have psoriasis, psoriatic arthritis, they have a higher likelihood of developing psoriatic arthritis. For those who have nail disease, it has been well described. We have been taught in medical school, psoriatic nail disease is not a psoriasis feature. It's only happened in 30% of the people with psoriasis, but in 80% of the people who have psoriatic arthritis, if you recognize the psoriatic nail disease, these are the group of people who have higher likelihood to develop into psoriatic arthritis. And let alone, now we know that obesity is one of the most important risk factors that drive people into psoriatic arthritis. So this leads to the collaborative care model. If you befriend your dermatology, educating them, and then have mutual learning, then you could possibly get a group of people who would progress to psoriatic arthritis earlier. So collaborative model actually come in different level. You doesn't necessarily to run a concurrent clinic with them. I mean, at the most simple way is get the number, get them into WhatsApp in case that they have a question, they have somebody to refer, they have a way to get to you. The most simple way. Of course, the medium is that you can have scientific meeting with them, discuss cases, and get the patients, and then you will have very good collaborative relationship. Of course, the highest commitment model would be combined clinic. I could understand that some of the rheumatology and dermatology department are really separated. Geographically it's difficult, but then if you have that kind of facilities or institution that can bring you together, running a combined clinic is something that is really educational to both sides. Patients love it. We publish our data on patient satisfaction. They like it. And then, of course, there are challenges like getting the clinic, the administrative, how to charge the patient, etc. I mean, in the GRAPPA guidelines, just now I showed the APNA guideline. GRAPPA guideline is also one of my babies. And then we emphasize all the time, treat to target, periodic comprehensive assessment. That is no difference from what the APNA guideline, ongoing assessment, treat to target. So we have ongoing new development of the drug. That is, we are lucky. And this slide is a little bit dated. We have much more nowadays. So, but then I want to say that development of drug is still very important. You look at this, no matter what class of drug that you are giving your patient, only 50% of them respond, which means that another 50% are not responding well. So we still need research to be around to give us better idea and better therapeutic target. That's only the ACR 20, 50, 70 respond, but I'd like to highlight that there's a huge amount of patients who do not really achieving good outcome, including remission and MDA. There are some of the things that we really need to think hard on how to curb it. So these are some of the comorbidities that is barring us for achieving very good outcome. Say, for example, obesity. Well, population studies have shown that people who are obese or having higher BMI, they all the time having higher pain score. Another important thing is the fibromyalgia or nociplastic pain or sensitization. People who have long-term pain, the brain is sort of changed in some way that they become more sensitized to pain. And of course, let alone to say, identify anxiety and depression. Some of the key unmet need is that a lack of biomarkers. When you're facing a patient in front of you, you sort of don't know what to give them to get the best response. So this is a very nice study by the Japanese group, Professor Tanaka. That group is trying to differentiate the cytokine profile by a flow cytometry and giving them a stratified therapy versus the standard therapy. So they have been able to show that the stratified DMARD therapy arm are able to achieve almost doubling of the outcomes. Of course, we wish that we have better biomarkers. Now we are using phenotype clinically. We look at the patient and see what domain that is affected and give them appropriate treatment. But hopefully we have biomarker somewhere, sometime, no matter it's genetic biomarker, whether it's immunomic biomarkers or proteomic biomarkers, metabolic biomarkers, or a combination of these that can help us to treat rheumatic disease as if we are treating cancer. I think that's also very promising in helping us to understand the pathogenesis of psoriatic arthritis better. That's very essential to identify the new therapeutic target. I think this is something up on the sky, right? We still need a lot of things to help us to validate and find which are the clear biomarkers of response. But I think to improve outcome for psoriatic arthritis, some of the things we already know. It's just that we need you and your colleague to work together and find out some of the model to come to early diagnosis. Be it going to the GP, talk to them, tell them that psoriasis, you might have arthritis risk. They might be triggered by innate immunity, which means that obesity will bring it on, the trauma will bring it on. Talk to your orthopod. Don't think that people who have psoriasis and an injury is just an injury. It might be a trigger that leading on to the psoriatic arthritis. And talk to your GP so that they are aware. Talk to your dermatologist so that they are willing to take off the shoes of the patient. A lot of time is that you just take off the shoes, the dactylitis is so obvious in their toes. And then effective treatment. I think that part is difficult. We all understand we want good treatment, but the drug access, but this is something that we need to work together, discuss with patient what is the best option, and give them the most appropriate treatment. Assess them, make sure that they are in the target that you want, and in future, we hope that we have biomarkers that help us to curb the disease better. So to this, I end here. So thank you very much for your attention. Thank you.
Thank you so much, Dr. Katy. We are pleased to welcome Dr. Aizad Mumtaz, consultant rheumatologist at NHS UK, a clinician and researcher whose work focuses on advancing the assessment and management of psoriatic disease through data-driven innovation and evidence-based approaches. Dr. Mumtaz will be sharing his insights on an exciting frontier in rheumatology, development of composite psoriatic disease activity index in psoriatic disease. Please join me in welcoming him to the stage.
So, hi everyone. It's good to be back to my hometown, and thank you to the PSR, Dr. Ahmed Said and Professor Mir for inviting me to share my work with you. So I will be focusing more on the clinical aspects. I'm not sure how many dermatologists are here in the room. Dr. Jahangir was one of my teachers in my medical school. So anyways, we'll start with that. So the topic of the talk is development of a composite psoriatic disease activity index. As you know, the new concept is that psoriatic arthritis is not just arthritis, it's psoriatic disease. It's a complex polygenic autoimmune disease with diverse clinical features. As indicated in this slide, that it affects multidimensional aspects of disease such as enthesitis, uveitis. It can cause extensive skin psoriasis, asymmetric sacroiliitis, inflammation in the spine, very extensive nail involvement, and dactylitis, and all of these have significant impact on patients' quality of life. So the reason we want to develop a composite psoriatic disease activity index is that psoriatic arthritis is an erosive and deforming arthritis occurring in 40 to 60% and is progressive from within first year of diagnosis. And disability and quality of life are adversely affected and to a degree equivalent to rheumatoid arthritis. The spectrum of psoriatic disease can vary from mild, moderate to very severe. And the patients may come to you with some or all of these features, and it's sometimes difficult to weigh their relative importance, in particular when making decisions regarding therapy. There are certain issues once we were developing this composite score, as previously Chris alluded to in his talk regarding systemic sclerosis as multi-system disease, and it affects various areas of the body. So patients in real life present with a mixture of features, and should the treatment decision be based on the worst feature or some composite index? And does severity grading depend on extent, potential for progression, or effect on function or quality of life? And thirdly, can we agree on the instruments with which to measure the various disease features? Can we adopt a mild, moderate, severe scale for each feature? And can we develop a tool which both assesses disease activity and measures the response to therapy as well? So these are the 5 domains that we used for the development of the composite disease activity index: the joint involvement, the skin involvement, enthesitis, dactylitis, and spinal disease. We based it on the initial GRAPPA recommendations and treatment recommendations, which most of the rheumatologists know. It involves treatment for the peripheral arthritis, the skin and nail disease, axial disease, dactylitis, and enthesitis, and then eventually reassess the response to therapy and toxicity as we go along. So this is the composite psoriatic disease activity index. As you know, the peripheral arthritis is assessed using the 66 Solon and 68 tender joint counts. The HAC is used to measure the effect on quality of life. The skin disease, as the dermatologists are well aware, is used with the PASI, and quality of life is assessed by the DLQI. Enthesitis was used using the Leeds Enthesitis score. Dactylitis was used with the Leeds Dactylitis Index and digit count, and spinal disease was used with the BASDI and ASCOL assessments. Then we defined the disease as mild, moderate, and severe. For peripheral arthritis, mild was described as less than equal to 4 joints with a normal function with a HAC of less than 0.5. Moderate disease was defined as less than equal to 4 joints but function impaired, and greater than 4 joints, normal function. Severe disease was described as greater than 4 joints as well as functional impairment. The skin disease, as the dermatologists know, is assessed with a PASI, and PASI of less than equal to 10 and DLQI of less than equal to 10 are categorized as mild, moderate, and then severe is to the other end of spectrum with a PASI of greater than 10 and a DLQI of greater than 10 as well. Enthesitis, again, is used with the Leeds Enthesitis score with more than 3 sites and functional impairment classifying as severe disease. Dactylitis, more than 3 digits and functional impairment classifies as severe disease. And spinal disease, which is quite frequently encountered in our patients, is the severe disease is classified as a BASDI of more than 4 and functional impairment in the ASCOL. Then we developed the CPDI and treatment implications, and mild disease was defined as a total score of 0 to less than 5. Treatment is symptomatic. Moderate was 5 to 6. This necessitated treatment with a disease-modifying therapy, and severe disease was defined as a score of greater than 6, and then we moved up to the next level. Importantly, consider moderate if any individual score, you get a score of 3. Consider severe if 2 individual scores score 3, and failure of response moves patients up to the next treatment phase. The treatment decisions are frequently driven by worse disease features. So we basically tested it in our busy rheumatology clinic at Dublin. All the patients were recruited from a rheumatology outpatients clinic. They satisfied the CASPAR criteria, and decision to undertake treatment was independently assessed by a rheumatologist. Baseline and those undergoing treatment change were followed up at 3 months. We collected around 117 PSA patients over a period of 12 months, 93 around Dublin, 24 around Leeds, 52 males with a median age at baseline of 47. Median duration of articular symptoms and of psoriasis was 10 months and 14 years, respectively. The time between psoriasis and psoriatic arthritis diagnosis was 5 years. The spinal component, the ASCOL and BASDI, were assessed only in 41 patients who gave a history of inflammatory type back pain. So as I mentioned, the ASCOL and BASDI were calculated in 41 patients. Of these, 39.34% had radiographic evidence of sacroiliitis. In those patients undergoing treatment change, the median value for the calculated CPDI, BASDI, and ASCOL were 9, 6.35, and 13 respectively. This is just a box plot representing the fact that I mentioned. On the left is the patients who are not requiring a treatment change, and on the right, we describe the patients who did undergo treatment change. We then tested the criterion validity, and the CPDI predicted a treatment change better than the DAS28 in patients with psoriatic arthritis. As you know, DAS28 is much more limited value in psoriatic disease. It correlated well with the DAS, the HAC, and patient and physician-related quality of life measures. It also showed responsiveness. At 3 months of follow-up, the median CPDI decreased from 8.5 to 5.5. The median HAC decreased from 0.85 to 0.57, and the median patient global also decreased from 6.9 to 3.4. In conclusion, this was the first attempt to develop a composite measure of psoriatic disease activity index activity, and was shown that it begins to satisfy the 3 components of the OMERACT filter, i.e. the truth, discrimination, and feasibility. It was able to distinguish patients with stable disease from those requiring a treatment change. It was also effective in predicting treatment change and also useful in measuring response to treatment. So eventually it was then validated in extensive GRAPPA exercise across 18 centers in around 20 countries. There were also other measures developed, as you know, the PASDAS, the MDA, the minimal disease activity, and the modified CPDI as well. But again, they have certain limitations in the sense that they're more driven by joint involvement and focus too much on joint involvement, leaving out other key components of the psoriatic disease. The CPDI was tested in the PRESTA trial, and the modified CPDI, which better reflects other domains such as skin, enthesitis, and dactylitis, was the only composite score which distinguished global treatment response between the two etanercept doses. This was in contrast to the DAPSA, which lays primary focus on assessment of joint disease activity only. I wanted to give you certain case-based scenarios for interest of dermatologists and rheumatology trainees, which will give you a good flavor of how we measure the disease activity and how the psoriatic disease is so difficult to treat as it is multifaceted. This was a 19-year-old male student, family history of psoriasis, presented with disabling bilateral Achilles tendonitis, right plantar fasciitis, unable to weight bear, significant impact on quality of life, initially unresponsive to the nonsteroidals, oral corticosteroids, physiotherapy, and right plantar fascia injection. His CPDI score was 2. He was commenced on DMARD, but may still require anti-TNF agent. So it gives you a flavor of enthesial involvement with impact on the patient. This was just the ultrasound showing the thickened plantar fascia insertion. The second case highlights joint involvement, post-articular synovitis for the past 2 years, having ongoing pain, swelling affecting the right middle finger, DIP joint, knee, also non-tender swollen right toe, widespread truncal psoriasis, so combination of joint and skin involvement. Previous treatments, no response to anti-inflammatories and topical steroid creams. So tender joint count was 2, swollen joint count 3. Significant hack, PASI and DLQI were also raised. CPDI calculated was 6. This was his joint involvement. The third case highlights the fact of significant disease activity in psoriatic disease. This was a 35 Caucasian lady, severe truncal and scalp psoriasis. She had initial response to topical treatment and PUA therapy, but failing effect. Her PASI was 46 and DLQI was 16. She also had inflammatory back pain, severe involvement with a BASDI of 6.4 and an ASCOL of 15. Her modified Schober was 2.5. There was radiological evidence of sacroiliitis. She had extensive joint involvement with 7 tender and 3 swollen joints. She had significant anthesial involvement. Enthesitis was present at 4 sites. She also had a dactylitic digit. The hack was quite impaired. Her inflammatory markers were raised, and her calculated CPDI score, unsurprisingly, was 14. And the last case is a 45-year-old male, psoriasis for the past 20 years. A PASI and DLQI were raised. He also had nail dystrophic changes, painful dactylitis affecting 2 fingers and 4 toes. Some improvement with previous methotrexate, but ongoing significant skin and nail involvement, and also dactylitis. His calculated score was 6. As 2 of his domains, the skin and dactylitis, scored 3, his overall disease activity was considered quite severe, and he was put on anti-TNF therapy. This is just a visual presentation. We also tested the CPDI and correlated with construct validity with the ultrasound assessment, and in essence, the CPDI scores did correlate with ultrasonographic findings of disease activity pre and post treatment. And this brings me to the conclusion of my talk. The purpose of the talk was to give you a flavor of how we measure the disease activity and response to therapy in such multifaceted disease. And it also helps you, both the dermatologists and the rheumatologists, in assessing the disease activity. And in many cases, the rheumatologists are limited in what they can offer to the patients, as the regulatory authorities don't allow for use of severe therapy or the next step of therapy. So once you have a composite measure, it helps both the dermatologists as well as the rheumatologists in getting the best treatment choice for their patients. So thank you very much, and we are open to all the questions.
We now proceed to our panel discussion on the topic, Unraveling Complexities at the Skin Joint Interface. We are pleased to invite our panel of experts featuring some very renowned names and dedicated clinicians from their respective fields of dermatology and rheumatology. We have with us Professor Azim Jahangir Khan, Professor Tariq Rasheed, Professor Tahir Kamal, Dr. Rafaqat Hameed, Dr. Ghulam Shabir, and Dr. Bilal Azim Butt, and also Dr. Sarmad Malik. This session will be moderated by Dr. Shamsuddin and Dr. Yasir Kamal from Center Park Medical and Teaching Hospital.
Assalamu alaikum. Excellent and very insightful talks regarding the psoriasis and psoriatic arthritis. Any questions from the audience for the speakers?
So thank you all for the wonderful and insightful talks. My name is Rasheed. I'm one of the rheumatologists. My real question is that in our daily practices, we do come across patients who don't have features of connective tissue disease, but they do tend to have a positive antibody, which comes back in a moderately high titer. And usually our practices is to rule out any systemic organ involvement. But do we need to follow them up? And if yes, how often do we need that?
Yeah, I'm not sure is this microphone working? Yes. So thank you for the question, and it's always nice to get a question from the lectern, because I feel slightly like we're more equal and less intimidated than from the audience. So I think it's a really important question, because as we get better at sort of making diagnosis, doing the tests or do more tests, you end up with this dilemma. I think the first thing to say is that if you first you have to be confident in your autoimmune serology. So in the UK, certainly we have a little bit of variability between labs, and so we often will check a test with two labs or a validation test. But if a patient has a significantly positive ANA that is disease associated, so from my point of view, a Scleroderma associated antibody like an anti-Sentinel antibody or an anti-SCL70 or U1RNP, then I think that you have to be very vigilant that you're not missing an early connective tissue disease. So that's for us that we've fortunately got access to very good microvascular diagnostics, so thermography and capillaroscopy. You can do capillaroscopy in the clinic with a dermatoscope, and that will be helpful. If the capillary is completely normal and there's no history of Raynaud's, does make a Scleroderma spectrum CTD very unlikely. But still, so I think if you've got no other findings, just the positive antibody, probably I wouldn't follow that patient up. But if you've got any hint, for instance, Raynaud's, abnormal nail file capillaries, or symptoms, then I think those patients, at the very least, should be seen in 1 year and have a clinical reassessment. I think, as we have discussed perhaps earlier today, if they start to show features of CTD, that's a little bit different, but that would allow you to intervene early. Thank you.
Thank you. The second question that I wanted to ask you was that, sorry, I work in the UK as well, so it's from there that sometimes as a baseline scleroderma lung profile, we come across the patients with very low DLCO, involvement of more than 20% over the lungs, and typical features of scleroderma. And ideally, we should be starting them on immunosuppression like MMF. But there were times when we discussed it with the centers and we went ahead with dual MMF and rituximab. So I just wanted your thoughts on that, whether there is any certain parameters that we should be looking for, or is it okay to start with one, observe in 3 months, and then proceed?
think that the first part of your question was also about the lung function, about DLCO. So a patient with a low DLCO, but without known lung fibrosis, or
with lung. So
lung
low DLCO, typical lung fibrosis, that's likely scleroderma related, requires immunosuppression.
Sure.
But the question is whether it's a dual with a biologic or a single
Okay,
one.
no, thank you. So I think the guidelines in our clinical practice would be that we would typically start with a single immunosuppressant with mycophenolate mofetil. There is, of course, the issue that I made the point that patients often start the MMF in diffuse scleroderma for the skin, and they may not, and then they may develop their lung fibrosis on that treatment. And in that case, that's really secondary progression, and that's when I would definitely consider adding something. And I think rituximab is probably my preferred, certainly the biologic I would most often add. In the UK, as you know, it's probably slightly easier to obtain than tocilizumab for patients with systemic sclerosis in the absence of arthritis. So yes, I would add, rituximab would be my first line to add an additional treatment to a patient who progressed on MMF, but the first line treatment for any patient with SSC and ILD would be just MMF, and our standard approach is to use 2 grams.
Thank you.
Thank you.
I have one question from you, sir. You mentioned that you use a durometry for checking skin thickness. I was thinking that as the device is very expensive, it may be.
Yeah.
So in common area, can we use some simple calipers for that?
So I should say that the point I was making really, I think durometry is, of the various mechanical approaches or biomechanical approaches that have been used, like elastometry and laser techniques, durometry seems to be the most robust, and it's relatively simple, and the devices, they're relatively expensive, but not as expensive as some of the other competitive devices. However, I think the point I would say is that there have been 2 or 3 studies now that really show that durometry, whilst it replicates the modified Rodnan skin score, it doesn't outperform it. So I think they've been very good at providing construct validity for the MRSS as measuring something useful in the skin. But I think outside a clinical trial, they are not used. We don't use them in our clinical practice outside a trial, but they're very useful. Where they are also useful is that there are trials emerging that are trying to just treat single areas of skin, for instance, with topical treatments, and that's where the MRSS is not really sensitive enough, but the durometry is one of the tools that can be used.
I basically wanted to ask that can we use some simple calipers that our endocrinology colleagues
so I
use
think in
for skin
theory
thickness?
you could. I mean, it would be another exercise in sort of validation, but I think personally, I do feel that actually the MRSS, if you're appropriately trained, and it's not difficult to be trained, and you're doing it regularly in your clinic, I think it's proven to be a very useful, simple tool, and the advantage it has is that it doesn't need special equipment cost. It just needs someone who's sort of competent. And I think that I was reassured again by what I showed you with our PASTEL, our patient self-assessment. I mean, it's a little flippant, but even the patient seems to be able to do the skin score in some way that is useful. So I think I would be an advocate, really, of MRSS, although it may seem a little bit simple. It's proven to be a useful assessment of skin, of what it is, which is an assessment of the total severity of the skin, the burden of skin thickening. But of course, that's not necessarily what is bothering our patients the most. I think that's the point.
Thank you. So one last question. You have mentioned several measures of disease activity of interstitial lung disease in scleroderma patients. Whenever a patient comes to us with worsening of shortness of breath and previously diagnosed as scleroderma-related ILD, we are confused actually whether the ILD has worsened or whether it is a complication of immune suppression like infections or pulmonary hypertension. Is there any score that can differentiate?
So I think, firstly, it's really helpful to me to come to here to talk with you and understand your practice, because clearly we worry about opportunistic infections, mainly PJP in our patients, but clearly we're not in an area where there are a lot of perhaps other infections, and it's perhaps a little bit less of a concern for us. So we are more likely just to kind of assume disease progression. So I think that differential diagnosis is really important. I think there's no substitute for careful investigation of the patient, but I think we use imaging mostly, CT scan, mostly when we're worried about defining true progression and also differentiating potential infection. And that's the one situation where we would do bronchoscopy and lavage in assessment of patients. So I think you've got to be careful in your assessment, which I'm sure you are. But imaging, CT imaging for us is I think the most useful way of discriminating. More, and we use that, of course. We use the lung function test and clinical assessment to identify when a patient needs repeat imaging, essentially.
So I have one question with Chris. So what about the overlap syndromes there? I have one patient who is an overlap of myositis with Scleroderma. Lady in her 60s presented with Raynaud's, swollen puffy fingers. We were monitoring her, and then initial ANA was negative, and then she seroconverted, and her anti-KU antibodies came back quite significantly positive, started developing muscle involvement, and then cardiac involvement. Her troponin started to rise. So your experience with this overlap syndrome, so we eventually treated her with cyclophosphamide, and now we have put her on MMF. She has responded from her around 70s all the time. So we sent her for a cardiac MR, and experts review with it at Scleroderma Center at Manchester. So what's your advice regarding these patients, and once you come across them, what's the prognosis?
So thank you very much for the really practical, important question. So firstly, our experience in our cohort is that about 17 to 18%, so 1 in 5 of our systemic sclerosis patients have overlap systemic sclerosis, and they will typically have an antibody that is more a feature of overlap scleroderma, U1RNP, anti-KU, anti-PMSCL. So again, the autoantibodies which are present at diagnosis usually, although occasionally can change during management, and that's another important message, that in those overlap patients, it's definitely worthwhile repeating the antibody testing periodically, perhaps annually, just to see if an antibody changes, because sometimes the antibody change precedes the clinical change. But I think anti-KU antibody is certainly a sort of red flag antibody for us to be looking for overlap patients, and particularly overlap with myositis or lupus features. But I think your question also brings up the challenge that even once you've diagnosed a potential problem, you can give the standard treatments, but in a multi-system disease, the same treatment isn't necessarily going to control all of the organs, and you bring up the point that cardiac involvement is a challenge. It's a big focus of research, but as I said in my talk this morning, one of the challenges is determining what's cardiac scleroderma or systemic sclerosis and what is just comorbidity, and that's where you do need imaging and experts. I think that in general, and it was in the BSR guidelines for management, fortunately, once you've got good cardiac assessment, you can then make a discussion about whether you're managing mainly a systolic dysfunction or diastolic dysfunction or myocarditis. But that's essentially the differentiation, and particularly in the patient you describe, the critical thing with imaging is to make sure whether or not there's evidence of inflammatory heart disease, and then you might think of adding another biologic. We would think of rituximab or tocilizumab.
I have a question. She has systemic sclerosis, and she was intolerant to MMF. She's quite stiff.
So at the moment she's having she's having rituximab, did you say? Tocilizumab. And she's not tolerating it, or is she? Right. Yeah. So the tocilizumab is working for her. So this is very important, and it was really we never expected tocilizumab would work for every patient, but we knew that there were some patients where it would be a very good treatment from their from their clinical and investigations, and that's been our experience as well. So I think we would generally just continue long-term with the tocilizumab. We have sometimes tried to increase the dosing interval. Some of our patients have done that, and they've reduced the frequency, but we would generally continue with the tocilizumab if it's possible. So thank you, and I can't think of a better topic to discuss in this forum of the sort of dermatology-rheumatology interaction. So I think, so what we have observed, we have a large cohort of patients, of course, that I'm definitely a splitter in the sense that I recognize the subtypes of patients that we see and how important it is to try and early on work out where the patient fits in within that sort of family of diseases. But to your point, we definitely know there is an overlap between localized scleroderma morphea and systemic sclerosis. So, and it works both ways. So we see some patients with systemic sclerosis who get typical plaques of morphea. Those patients are typically limited cutaneous systemic sclerosis. Patients who often have sites of trauma can get morphea-like lesions or with venous insufficiency on the lower limbs. So those patients get this clinical problem of localized scleroderma morphea in the context of limited cutaneous disease. The other classical group that we've published on, and we did a nice molecular study on, are patients with diffuse scleroderma who get nodular morphea, little nodules of morphea. And again, I think that reflects a systemic process, but it's a localized skin problem. The other group of patients, that perhaps is what you allude to, is those patients who have more classical morphea, often linear scleroderma or pansclerotic morphea or even fasciitis, who also show some features of systemic sclerosis. And I agree those patients are definitely out there and they need careful management because there is a risk of misdiagnosis. You don't want to treat a patient who's essentially got localized scleroderma or morphea just because they've got an antibody or some Raynaud's phenomenon. They shouldn't be managed as systemic sclerosis, they should be managed for their morphea. But likewise, you want to recognize that those patients exist. So I think it is an example where you need to jointly assess and manage the patients. But in answer to your treatment concerns, or patients with very bad morphea, for example, particularly pansclerotic or generalized morphea, we will manage those in conjunction with our dermatologist very intensively. So we will use exactly the same treatments we would use in severe systemic sclerosis, up to and including cyclophosphamide, but certainly drugs such as mycophenolate and methotrexate in combinations. The one difference for our severe morphea patients is we also use calcineurin antagonists like cyclosporin or tacrolimus, which we don't use in systemic sclerosis usually.
Well, one related question was that have you experienced any topical JAK inhibitors for the linear morphea?
So that's a really good question, and the answer is I've not experienced yet of topical JAK inhibitors, but we are attracted for skin disease. The idea of topical treatment is attractive. We talked a little bit about that's where the durometer might be useful because you could be sort of really assessing in detail the change in skin at one location. We use a lot of topical tacrolimus, protopic, because obviously it's easily available, and we use that as a very useful add-on treatment for skin disease, particularly in morphea. But I think there's potential. Of course, the real challenge with all of those is the penetration. Unfortunately, most studies of topical treatments for systemic sclerosis have failed because I think the drug doesn't penetrate the sclerotic skin. So that's a challenge compared to using it for an epidermal skin problem.
Thank you very much.
I am Dr. Tariq, Rasheed, dermatologist. When a patient comes to us with skin extensive fibrosis of systemic sclerosis, and considering skin fibrosis, we want to start the patient either with methotrexate or mycophenolate mofetil. And after starting methotrexate, after 3 to 4 months, we see that the response is not adequate. And then we have to switch to mycophenolate mofetil. I want to know, are there any clinical or biochemical markers, anything which would guide us which drug to select for this specific patient so that time is not wasted?
Yeah, no, that's a really topical question because that is exactly what we've been doing actually, and we've published recently in the last 4 or 5 years, really extensive molecular subtyping of our patients exactly for that reason. And so interestingly, the different autoantibodies I talk about, so for a systemic sclerosis with diffuse skin, in our practice, most of the patients either have anti-SCL70 or anti-RNA polymerase 3, so these hallmark antibodies. We can find definite molecular and pathway differences when we do the skin biopsies, and we've published this. And of course, that's not yet ready to move into clinical practice, but it suggests that your idea is absolutely right, that we should maybe in the future be able to predict better. At the moment, we still are really restricted to using the autoantibodies as a surrogate for those subtypes. Interestingly, the patients like you described, I often see those as patients who have the anti-RNA polymerase antibody. They have a very slow response to the standard immunosuppressants, and you often have to wait 6 or 9 months. And we generally, in those patients, we add treatments rather than switch, because what we have seen in those patients where there's not been a good response after 6 months is we used to switch. So we'd stop, for instance, methotrexate and add in and then restart mycophenolate. What we often saw in the 3 to 6 months after stopping a drug you thought wasn't working, that the skin suddenly got a lot worse. So it's not that the drug wasn't working at all, it just was not sufficient. And so for that reason, we now add drugs. So we will usually add a second drug and then potentially wean off the first one. But I think it's an important point. And another example, what we would typically do, I think these days, if we could, we'd usually start with mycophenolate. We use methotrexate more in overlap syndromes, but a typical patient will have one of those drugs, and then we would these days probably add rituximab because it's been shown to be very good for the skin. So if we had access to it, we would probably use that as a second line.
Is there any scenario in which we can start right away from the very beginning, rituximab, if there is extensive fibrosis, and so hit hard and control the disease aggressively, rather than going to traditional methotrexate?
You mean starting as a first-line treatment with rituximab, you're thinking? So, I mean, the Japanese Desires trial used just rituximab, so it can be used in that situation as a single treatment. In our practice, in the UK, we have some restrictions to access to the biologics that really mean that it's very hard to give a biologic like rituximab as a first-line treatment without a concurrent diagnosis of either myositis or vasculitis. So for that reason, we're treating them much more like an arthritis patient. We're adding it second line. But I think you could do that. The only question, at least in our practice, because we have ready access to mycophenolate and we know it's generally very effective, and in some patients it is the only treatment that they need, that's why we would sort of classify our patients, if you like, as to a mycophenolate responder or non-responder, and the non-responders are where we add other drugs. But that's really perhaps appropriate to our practice. It might be different in other regions.
Regarding psoriatic arthritis, because the traditional DMRDs like methotrexate and cyclosporine are not going to inhibit the skeletal progression of the disease, like erosions would not be inhibited by these traditional disease-modifying agents. So what is the role and place of these drugs now in the management of psoriatic arthritis? Should we go right away to biologics rather than going to all these methotrexate and this?
Well, it's not an easy question to answer. It's like we now have very good data to show that if you first line giving them a TNF blocker, it's much better than methotrexate alone. But and then at the same time, if you look into people who are given methotrexate, they are not totally without a response. Yeah. So then it's a balance. So if you give biologic as a start, you are bound to overtreat some of these patients. While you are giving methotrexate or other conventional DMARD to all the patients, you are undertreating them. So the key thing is how to differentiate who would have worse prognosis, that you give them a powerful medication, where the milder, you give them a milder medication. That is a $1 million, several $1 million question to answer. What are the prognostic markers that we can look into and give them the appropriate treatment? I mean, there are some that
I mean, if they have a lot of joints to start with, very high burden of illness, you would literally know that if you give them a methotrexate 6 months later, they are going to go on to something else. The key thing is that at the moment, while we lack of a biomarkers that tell you exactly what the cost might be, and evaluating the cost and benefit ratio, then we usually start with the conventional Derma and see how they are doing. If they are not doing that, not achieving the target that you want them to be, go ahead to go on to the next level of treatment, then give them a very good response. I mean, that is the practical approach until we find a better solution to that situation.
Another concern is that when we start secukinumab IL-17 inhibitor to a patient, and initially for 1.5 to 2 years, there is a good response, both skin disease and arthritis. But again, the patient is on the treatment, but resistance swell, there is a relapse of skin disease, and even recurrence of psoriatic arthritis. So at that stage, what strategies could be done, preferred strategies in that case?
We don't have very good data, don't have that kind of trials that give us a randomized controlled trial level 1 evidence to tell you what to do. I think nowadays we are more open to combination of biologics or targeted synthetic Derma. And I'm sure that we will know a little bit more how to combine these agents. Say, for example, try not to combine TNF together with a JAK. It might have more side effect, but probably interleukin 17 together with a JAK is not too bad. So we will start to have that kind of situation more and more. People will have other extra articular manifestations, psoriasis, and then they are on interleukin 17, and then they still have a flare. What are you going to do? Are you giving them a JAK for a short period of time until you suppress the arthritis down and then you taper it off? It might be that kind of option. I think now I cannot give you a definite answer because there is no trial to support me. That is my postulation, wild guess. So, but then we will learn a little bit more over the years. How are we going to manage this kind of patients? Like those with IBD, they are well treated and suddenly they have a joint flare or eye flare. What are you going to do? So I think that might be the way to go.
Thank you very much.
I just wanted to comment that I generally feel that as with anti-TNF, whenever we give them with methotrexate, it prevents the development of antibodies. So I just have a thought that maybe, yes, sir was talking about IL-17 inhibitors. Maybe if we start methotrexate along initially and then add IL-17 inhibitors and follow the patient for a few years, that he's saying that they develop a flare, maybe that's due to a late development of antibodies that might affect that. That's just a thought that I think. So.
One day ago was a lot of the patients are not on the correct dose of methotrexate. Yes. We don't really do. We are also complacent in this kind of approach because there's no standardized approach along different centers. How do we initiate methotrexate and go to the effective dose of 25 milligrams? There's a huge discrepancy even in UK as well. Different centers using different approaches. And the main idea that I got from that talk was you need to hit hard, hit early, go to the effective dose of 25 milligrams, and then assess the response. And then again, the current trend is combination therapies and switch around till you get the disease remission. So one of my questions to our dermatologists and to you guys is, do you guys do combined skin and rheumatology clinics? Because that's the thing that is extremely important. In which you can sit down, get the expertise of our dermatology colleagues, and they can get our expertise, and that's where the composite disease activity index comes in. You know, so, yeah.
So we actually land.
Yeah.
Actually land actually to Dr. Park and we land for my journal. But as I mentioned, sometimes we have plans to screen and one of the things that
But Pakistan is very, very convenient in two ways. Number one, you don't need a primary care approval to go to a dermatologist or rheumatologist. Anybody can go to anybody, most welcome. So that's the good thing. The other thing is that since people pay out of pocket, so we don't have to jump through the hoops of approvals or insurance approvals or the governmental approvals. So you can go directly to the best therapy. Again, the question that Dr. Tariq also asked, that there are certain diseases in which I understand, and I trained in the US, and there even more regulatory stuff from the insurance companies. They don't want us to put people on expensive medicine when something can be treated with methotrexate, right? But question is that if you leave those things aside, from the efficacy standpoint, do we have to, I mean, if we don't have any restrictions of the money involved with the agents, would you put people on aggressive disease directly on biologics or not? That was a question that is on the mind of a lot of us, that if we know that somebody is having aggressive disease, for example, Scleroderma, and I've seen people who, in front of our own eyes, they rapidly progress. And then once they have progressed, and we are already coordinating with our rheumatology colleagues, pulmonology colleagues, nephrology colleagues, and then you scratch your heads and think that had we put this patient on a stronger agent, could we have stopped the progression of the disease? So purely based on science, forget about what the recommendations or guidelines say.
So just to sort of say from a systemic sclerosis perspective, because it follows on perhaps from the question earlier about whether you would want to use rituximab first line. I think in systemic sclerosis we've learned, and we learned a lot from the management of pulmonary arterial hypertension and systemic sclerosis, which for us 2 decades ago we were the first oral drug that we could use, and now we've got a lot of drugs, but we've learned from the pulmonary hypertension specialists that when you have a very severe patient with poor prognosis, you need initial combination therapy, what they would call upfront combination therapy. And I think the same is probably true certainly for systemic sclerosis. That's what we would be looking for, rather than, because I don't think there's enough evidence, at least in my practice, to say that a single agent biologic is better than MMF, for example. A single agent, there's no good evidence that one will outperform the other consistently, but different patients may respond differently to those. But if you've got a patient who's very severe with very poor prognostic markers, the sort of patient we would be considering for an autologous stem cell transplant, that's the sort of patient where I would say a very reasonable alternative would be upfront combination of conventional DMARD and biologic, and really maximally treat those patients. But I think that's something we've learned, at least for pulmonary hypertension, has really made a big difference, with the caveat that you do need effective drugs. And sotatercept, which is the new drug for pulmonary hypertension, is the first drug that probably has had the clinical impact to really show the benefit of that immediate therapy in very, very sick patients. So that's true for systemic sclerosis, but it might be different for psoriatic arthritis.
I think that's a difficult question. I mean, if you are in the shoe of a patient, if money is not a concern, I would probably choose whatever much powerful to suppress my disease and get back my quality of life. But I think even if you are treating everybody with the biologic right away, I think some of the disease, they will still come. Say, for example, people who have been, the example that you are citing, that have very good control with the biologic, the joint will still flare. There will be some patients that the domain may not be mediated by the same mechanism of the disease. We were bound to see them as the natural cause of disease. It's like we have been trying to think whether we treat psoriasis very early before they have arthritis. Can we totally prevent arthritis and wipe out of industry? Possibly be that that my wild guess. We will be reducing the number of people who have psoriatic arthritis. But think about that. There are some patients who start with arthritis without anything, and until they suddenly have a scalp lesion, then you think that this might be psoriatic arthritis rather than rheumatoid arthritis that you have been labeling them. So I think there would be a lot more underlying pathophysiology, pathogenesis that we have not understood totally. That's why the research is there and telling us that these heterogeneous disease might be mediated by different pathways.
My comment was on the patient on secukinumab who are doing well, they continue to do well. And whenever they have flare of the skin, normally they are on 150 milligram dosage for psoriatic arthritis. Whenever we increase the dosage to 300 milligram, they did respond. So they continue to do well on monotherapy rather than adding methotrexate or any other agent.
Just a question from Dr. Azim Jahangir. Sir, in patients with only skin psoriasis and without any arthritis and a nail involvement, what is your threshold for starting methotrexate? Because in regular clinical practice in our rheumatology clinics, we usually see that the patients are only on 10 milligram of methotrexate. Might be this is delaying their arthritis, and we just want to know what is your threshold that you switch from local application to a immunosuppressive agent?
The general guideline is that the more than 30% skin involvement. So, but again, those are the guidelines. If somebody is having only skin psoriasis without any involvement of the joints, I think we should try, and that's the recommendation, we should try at every cost the systemic therapy, because we don't know that how many people will progress on to having joint disease. Since we don't know, so the preferred choice is that if it's less than 30%, then we try to put them on topicals, because now we have very, very excellent topicals. The problem is that they cannot put the topicals all over the body. So then we go on to narrowband UVB. Interestingly, and I don't know the data, but I was going to dig in some data, that when you put some people on narrowband UVB and they are waiting to be seen by a rheumatologist, they start feeling better in their joints also. I don't know, their inflammatory markers go down, and then they refuse to go there because their joints have started to get better. So they may not have the arthritis, they may have some arthropathy or some, so if somebody is not controlled on the topicals, then the orals we should, I don't think that we start on the highest dose. I usually start like 10 or 15 milligrams a day, depending on the kind of patient, how big is the patient. But usually we try to keep the, because we are not looking forward to have a joint disease in very near future. So most of the people do well on the smaller dose. Now, the flip side from a rheumatologic point of view is that probably we could have given them a higher dose to prevent the arthritis. So if you look at the data, I'm sure that you might know better than me, that the chances of somebody having a small patch of psoriasis still getting into arthritis, psoriatic arthritis is still there. And there are people who only have psoriasis on the scalp, literally one patch of psoriasis. And some people get psoriatic arthritis prior to getting actually the skin psoriasis. So the problem is that since we don't know who's going to graduate into psoriatic arthritis, we don't want to put the people on a very high dose. That's my approach.
There is a difference in the dosing regimen between, I think, for the psoriatic arthritis and psoriatic skin disease. Because in all dermatological disease, psoriasis skin disease, the dose is limited. We usually start with 7.5 milligram. And the guidelines say that use the minimum possible dose which would control the disease, not the maximum. So most of the skin manifestations are controlled even with 7.5 milligram, 10 milligram. We hardly go to 15 milligram. But I think the skin joints manifestations, you need even 30 milligram dose. So there is a difference in the disparity of the doses.
Just the last question from Katy. Have you experienced that secukinumab efficiency is reduced because of anti-drug antibodies or have you measured any anti-drug antibodies in patients which doesn't respond to this drug secukinumab?
I do not have data because we don't check the secukinumab antibody. So, the comment about secukinumab, I think secukinumab is very dose dependent. And then if you look into the initial Future 1 trial, they failed badly because the dose was 75 mg. And a lot of time we use secukinumab, we do away with the 150, we start with 300. And interestingly, the skin dose is a little bit higher than the joint dose. Yeah, this is the reverse for methotrexate. Usually the methotrexate, then you need a lower dose for the skin response, you need a higher dose for joint response. But secukinumab, beware of the dosing.
We are running out of time. Thank you very much, our speakers in the panel of experts. Thank you. We conclude here this session. So,
Thank you so much, everyone. You can please take your seat in the audience. I would now request Dr. Rafaqat Hameed and Dr. Bilal Azim Butt to please present the token of appreciation to our speaker, Dr. Aizad Mumtaz.
We would request Dr. Tariq Rasheed to present the token of appreciation to our expert panelists, please. Professor Dr. Azim Jahangir Khan.
Dr. Tahir Kamal.
Dr. Ghulam Shabir.
Dr. Azim Jahangir Khan. Dr. Bilal Azim Butt. Dr. Rafaqat Hameed.
Dr. Sarmad Malik. And now I would like Dr. Bilal Azim and Dr. Bilal Azim and Dr. Azim Jahangir to present a token of appreciation to Dr. Rafaqat Hameed. With that, we conclude this session. We now warmly invite all of our esteemed guests and participants to join us for an exquisite evening at the conference dinner taking place at 7:45 p.m. in the Grand Ballroom B, courtesy of Hirani's Pharma. We look forward to your presence for an evening of fine dining, engaging conversations, and wonderful company. Thank you.